Hello, my name is James Roberts. I am a physiotherapist by background and have a special interest in shoulders, in particular sort of assessment and subsequent management. And I've been asked by Marcus to deliver a talk specifically talking about rehabilitation principles for the sort of non-traumatic shoulder. Specifically, I'll be sort of talking more classically what you might have heard termed as impingement, rotator cuff tendinopathy, rotator cuff related shoulder pain, subacromial pain syndrome, amongst others. But look, we'll look to talk to that as the talk goes along. So obviously, this talk is specifically aimed towards people that will be delivering conservative management to these patients. So first thing I want to talk to very sort of specifically is that, what should we not be treating? What signs and symptoms might make us worry, and certainly patients that I feel it's unlikely you're going to see any success with, or actually medical management needs to be altered very urgently. What can we do to predict response? What prognostic variables are we aware of in this group of patients? To try and talk a little bit about my rehab principles for rotator cuff related shoulder pain. And then to give you sort of a few exercise examples that I might use commonly in clinic. So first of all, look, the idea of this talk is specifically guided towards treatment. But look, if anyone wants any sort of further advice on sort of shoulder assessment, I think a very good summary points can be found as under the sort of clinical knowledge summaries provided by NICE, website there, and through sort of BESS or the British Orthopaedic Association. Again, you can sort of find the links there, but I think look to evolve and sort of break down assessment, but and some key principles. So red flags, I'm sure all of this is common, but I always think it's important to sort of talk. Any unexplained soft tissue mass, swelling, severe unremitting night pain, past medical history of cancer, certainly may well be and most patients that are systemically unwell certainly might make you think that other things are going on and should certainly be considered for ongoing medical management and assessment certainly with our medical colleagues, and depending on your suspicions, should be treated urgently, certainly if suspected. Obviously, it may well be that you've had somebody with perhaps some traumatic issues, in particular trauma, dislocation, trauma and suspected rotator cuff tear is likely to need onward referral for an orthopaedic opinion. Anyone sort of explaining with or complaining rather of some sort of more inflammatory type features, particularly that of sort of more peripheral spondyloarthropathy type features, other enthesitis that you might be looking for. You might be looking for nail pitting, dactylitis, early morning sort of pattern, for example, which again, I'm sure you're all familiar with. But equally not to differentiate from something called polymyalgia rheumatica, certainly in the over 60s and more commonly seen more bilaterally, should certainly have raised suspicions if you're seeing ongoing stiffness for over 45 minutes that may present with other features. Again, a lot of information can be found online. You can get some vascular presentations and certainly DVTs, certainly more uncommon. So look, just a very, very broad overview. You can find more via those NICE clinical knowledge summaries, but certainly these are red flags that if patients are presenting with, you'd want to refer those onwards. But what else would I consider for an early onward referral? Now I've touched upon this already, but certainly post-traumatic severe pain, suspected rotator cuff tears, and certainly dislocations. Recurrent and ongoing instability, and as well as that, if a patient is having significant problems in function, sleep, work, their sporting occupation hobbies, then certainly consideration involving our colleagues such as Marcus in with his patients is likely to be important. So look, first of all, what information can we get from the patient that might help predict if this is likely to respond well in this group of patients? So there was a really good cohort trial done by Rachel Chester a few years back. And essentially this paper showed that those with a higher pain self-efficacy, those with good expectations of sort of complete recovery, and certainly those with lower baseline disabilities and lower pain levels at rest are more likely to sort of have a better outcome as such. So straight away, you know, trying to sort of stratify those who might not do as well is hopefully likely to guide you to those patients that are more likely to sort of need a greater level and structure of support, perhaps, to help hopefully, you know, impact and improve their outcomes. You've also got this paper here, back from sort of 2013, which, you know, was a pretty large study actually, and around 20% of sort of patients, you know, went on to undergo surgery, and I believe there was over 700 sort of patients in total. But probably one of the biggest predictors that was shown to be related to a successful outcome was patients' expectations of physiotherapy, interestingly enough. So, you know, we're starting to sort of touch upon really those sort of subjective features that might, you know, well be worth trying to screen into as part of your medical examination, that might start giving you an idea as to how well a patient is likely to respond, but equally those who you might need to give more support to as well. And, you know, there's this term subacromial impingement syndrome, which certainly has fallen out of favour, and certainly the theoretical underpinning and principles have sort of really been shown to be nothing more than a theoretical model, and certainly not something that we sort of expect to see in patients. But, you know, similar links to patients. So Andrew Cuff did a study, qualitative study, back in I'm scratching here, but I think it was 2016. I do have a reference to come. And essentially, they interviewed patients that have been referred over from orthopaedic colleagues with a diagnosis of subacromial impingement and, you know, review of investigations. And before starting any sort of conservative measures, here's a few direct quotes that were given by the patients. So, look, my shoulder pain's being caused by this bit of tendon that's being caught by this piece of bone, and that's what's wearing it away. They told me there's some inflammation and there's something that's rubbing, and that every time it rubs, that's what's causing me to have pain. If there's a physical lump or something there, all the physio in the world isn't going to resolve this. And I said to the physio, I think the only way that it's going to permanently cure this is through surgery. So when we start to understand patients' expectations, hopefully these quotes start to bring to light why it's important to get an idea as to what their expectations might be from you before you begin treatment. And I think the more we can understand that, hopefully the more we can direct management most appropriately. Now, when we sort of talk about rehab, I've got perhaps some sort of general principles that I like to sort of touch base and sort of keep on board. And I think exercises should be mapped to function. You know, if you've got a patient that is, let's say, an overhead tennis player, and their problems are in abduction, external rotation, that's where the rehab should be focused towards. I think we're all guilty of this, myself included, but sometimes we don't challenge or push patients hard enough. And I will look to touch upon what I mean by sufficient dosage. I think that we should be thinking broader. Many conditions, musculoskeletal conditions, have great associations with other medical conditions. So improving someone's metabolic health and increasing physical activity should be an equal requirement of what we are delivering. And probably it's not enough to just deliver exercises on a sheet of paper, video, whatever that might be. You know, we might really need to be trying to get some sort of, you know, underlying behaviour change to improve general physical activity levels, as well as exercises that may well challenge some of their expectations. And for a little bit more information, you know, about, you know, when we start thinking about not just managing a shoulder, but, you know, instead of treating in silos as such, we should be thinking more broadly, improving, you know, general communication skills, you know, enhancing active learning approaches, encouraging self-management and considering, comorbidities as represented by JP Canero's study back from 2019. So what evidence currently supports rehab of the shoulder? First one, progressive resistance programs certainly appear to have a great degree of benefit, and this study from Littlewood back in 2016 certainly brought a lot of that to light. And certainly progressive resistance programs seem to have the most beneficial effect. The use of force plates and looking certainly at sort of more maximal voluntary contractions has been looked at by Ben Ashworth a few years ago, and they're particularly they're sort of looking at not just the isometric power, but that rate of force development. And certainly in the more athletic population, it may not well just be about improving resistance, but the speed of resistance. And particularly think of those more athletic patients. Or those patients that might actually only really be having symptoms with with faster movements, maybe that might be what needs challenging. There's a link between hand grip strength, so thinking of the whole arm or the whole of the sort of proximal and distal limb as part of rehab. And look, highlighting what I've sort of said before, that actually if a patient's expectations of physio are pretty low, maybe that's where you might need more time discussing some of their sort of thoughts and beliefs and seeing if you're able to influence those. Now, in terms of underlying principles for rehabilitation, I'm trying to think about a clinical reasoning behind exercise prescription. Certainly this study by Karen Jin's group that looks to sort of talk about the stabilising muscle groups. So during flexion, the key co-contractors, you're expecting to see posterior cuff working as a stabiliser. During extension, you're expecting the anterior cuff to act as a stabiliser. And during abduction motions, you're expecting all of the rotator cuff to be working. And the role of these rotator cuff differs when the arm is supported versus unsupported. So thinking about the direction and the degree of support that you provide during exercises is supported certainly through these studies as part of a rehabilitation approach. This very, very hot off the press study, which looked at exercise approaches for the shoulder, certainly showed that steroid injections may well have a short beneficial effect in the short term. But generally, whether you treat somebody with a one session and direct towards self-management versus whether you follow that up over six sessions, showed very limited difference over a 16-week period. So I think that again highlights what I mentioned earlier about behaviour change, put patients in control of their exercises, trying to give them a better understanding about shoulder pathology and shoulder problems, and a better cause of their symptoms. I think is certainly going to be beneficial for patients and their longer term outcome. So, a very simple model is, look, we devise the exercise that we think to give them, we give them a sets and reps, sufficient rest in between, and they're likely to be successful. And I think, look, we probably know straight away that prescribing exercise isn't anywhere near as straightforward as this. So dosage. Now, essentially for shoulder problems, we don't know what the correct dosage is, and particularly, for this rotator cuff related shoulder pain. But what we do know is probably it needs to have at least 3 sets. It needs to be progressive in resistance, and patients need to be doing this for at least 12 weeks. And certainly from a review of the evidence, this has certainly seemed to be what's been found. But can we be more specific from this? And this is taken from these infographics, and have been taken from a patellofemoral paper written by Simon Lack again a few years ago. And essentially, obviously, what we're sort of looking from here is, are you trying to change strength? Are you trying to change power? Are you trying to, facilitate more neuromuscular activation? Are you trying to facilitate endurance? And a lot of that may well come from your physical examination or your, impairment testing as part of your examination. It may well be related to the individual themselves. But that way, you're trying to think about sets repetitions, and how hard that you might be able to work these patients. But I do appreciate dosage in clinic, is not always feasible to be working towards certain percentages of 1 rep maximum. And generally that's when I would use an RPE scale, and generally I would be looking to get people working at a minimum of a 3 to 4 effort, if 10's maximum effort. And depending on what variable that I'm trying to influence would then certainly dictate how high I would push them up the RPE. And obviously that would be up to your clinical reasoning to differentiate that. So I think that making sure that you sufficiently dosage a patient's exercise is likely to impact upon their outcome. However, I think that statement in itself certainly has been under some challenge of recently, certainly by the Sexy trial by Beck, published this year. And certainly, there's no sort of clear answer that more resistance and greater resistance leads to better outcomes. So I think, it does come down to clinical reasoning, and it is likely to be very individual to the patient. I've finished on individual rehab approaches there, and you do need to tailor a rehabilitation approach, depending on their age, their lifestyle, their health status, their attitudes, their beliefs, and the patient's expectations mean that you're likely to need to tailor a rehabilitation to an individual. And I think some of these points here, obviously patients will come to see you as a professional, but patients aren't always compliant with exercise programs. And as mentioned earlier, if you want to be, seeing the best outcomes, you need to be engaging a patient with a minimum of 12 weeks. And actually, a lot of the literature with musculoskeletal conditions has been shown that, up to 70% of people do not adhere to exercise programs. And these are the features that are likely to predict whether a patient is more likely to adhere. I'm not sure I'm happy with the word adherence, but engage with an exercise program. So actually, consideration of these variables, such as their general levels of physical activity, their levels of self-efficacy, their mental health status, the degree of social support that they get, what barriers and they have to exercise and what expectations they may have, and pain levels that they experience during exercise are likely to be linked as to whether a patient is compliant in your program. So again, similar topics to what I've said before, understanding these barriers is likely to be important when we think about engagement in an exercise program. And the reference is sort of tucked behind there rather poorly, sorry, on my behalf, but hopefully you can see the reference there. And, that is barriers to treatment adherence in physiotherapy outpatient clinics. And building upon some of those points there, why I said sort of, about exercise adherence, because look, it's been shown that patients tend to avoid activity if it causes pain. And, not everyone believes that exercise, the benefits outweigh the risks. And depending on the diagnosis that is given, patients may well have quite negative connotations that link to exercise. So again, understanding patients' concerns, beliefs, expectations, again, is likely to be critical as part of the rehabilitation strategy. And look, should exercises be painful? I think there's a growing belief that certainly in more tendinopathy that, we look to treating towards pain. But certainly, I am of the opinion that working into a tolerable level of discomfort, as long as there's not a flare of symptoms afterwards, is likely to be manageable for a patient and may well actually have more beneficial aspects related to that. And if you'd like some sort of more patient-facing resources to help support and guide your conversation, there's a few resources here that have been provided by the sort of British Elbow and Shoulder Society that I think are useful. So I've put a few rehabilitation programs here. So for patients with atraumatic shoulder instability, the Derby shoulder instability program has certainly been shown to have good early and mid outcomes. And certainly the paper expands on that quite well, but they are looking at a combination of sort of proprioceptive work as well as how quickly these muscles are working. And again, as I said, these are the proprioceptive exercises, and the exercises before were the speed type exercises. And again, obviously you're choosing one exercise from each section, and it allows an ability for a patient to self-progress through, and that will be for a diagnosis of atraumatic instability. For those patients with a weak painful shoulder, or what we might call subacromial pain syndrome, impingement, rotator cuff related shoulder pain. As I've mentioned earlier, I'm not happy with the word impingement, and that's due to those qualitative studies. But it may well be that you're looking to initially start with some isometric type exercises, and you're trying to map that to function, whether that's in an externally rotated abductive position, as the first two pictures might show. However, it might be that you choose to work that into more extremes of range. But again, that would depend on what the patient is struggling with. I'm certainly working through extremes of range, and you may well want to work into those extremes of range with more support. And part of that will depend on whether you're trying to engage the stabilizing function of a rotator cuff, as discussed by that Karen Jin's group paper, and working into a different range. Similar sort of question being asked from your second exercises, sort of a prone shoulder external rotation. You may or may not have more support underneath the shoulder, again trying to target posterior rotator cuff. And certainly it might be that a patient is actually only struggling with pain reaching in behind the back, and it might be that you're wanting to work posterior cuff eccentrically into those sort of positions. So again, key takeaway from some of these exercises are that you want to map exercises to their functional limitations and restrictions. It might be that you might want to look into that in more higher level. And the idea of these exercises, so for example, the top one is if a patient is suffering with problems in a more elevated position, then certainly trying to engage rotator cuff, posterior rotator cuff in particular in more overhead positions may well be the aim of a session. Commonly, you may well experience people experiencing pain across the body, taking off t-shirts. Again, I tend to find these below exercises quite useful. And the last exercise, a prone overhead external rotation press for those patients, again, wanting to work in more overhead positions. To try and improve a little bit of stability or a little bit of rotator cuff power, is a couple of examples that I might use for the overhead, but also some easy ways to progress strength and endurance into those overhead positions of a posterior rotator cuff. And so progressions of sort of speed of movements may well be that you're looking for, so for example, the first exercise, and that's as quick as these videos will capture, but you're almost doing like a drop and a catch. You imagine those patients with apprehension into sort of more abduction, externally rotated positions. It might be that you, the weightlifter, but struggling to get that sort of rate of force development working between those positions, that I might look to drop a bar with a bit of instability and then catch him, which is what the first picture will represent. And sort of progressed into these sort of positions here. It may well be that you're trying to work some of the proprioceptive work into the overhead, so looking into push-ups with a greater degree of sort of proprioceptive into some more extreme positions. And similar concepts, working through the unstable shoulder, some sort of variations really of Marcus Bateman's Derby shoulder instability program may well be working into some sort of speed positions there, and changing the position and objects that you used in order to challenge that stability can be important, alongside perhaps getting the kinetic chain going. It may well be that you're trying to generate the eccentric function of the posterior rotator cuff. And again, almost those throwing athletes, this is a nice exercise that I like to use. And certainly there's a growing degree of literature that sort of looks to, the posterior eccentric function of the shoulder. And again, some sort of further stability programs overhead pressing, involvement of the kinetic chain, or drop and catching of the body. And certainly this is a very, very higher level, and almost, getting to the point of return to play type testing criteria. And more, stability for anterior cuff, as well as some sort of speed work that I'd be thrown with those sort of plyo balls. Again, progressions of posterior rotator cuff, overhead press, working the shoulder, the unstable shoulder into these more abducted, externally rotated positions in unstable positions by getting the kinetic chain going. Or it might be that actually you're doing some sort of drop catch of a cable bar, again, to try and get that rate of force development, of those rotator cuff or those stabilizing shoulder muscles. Now, look, this has been very much a whistle-stop tour, and the key that I wanted to get from this is to consider how broad and vast rehabilitation approaches are likely to be for the shoulder, and particularly for that sort of muscle group, and that there's so many considerations that you do need to take on board. And I'm very, very aware that this is very much a whistle-stop tour. And, in support with Marcus, I would be happy if anyone wanted to reach out, ask questions of me about any of that sort of talk, or even for, for sort of future discussion. And certainly my Queen Mary's email can be gained from Marcus if anyone would like to get in touch via email for me to discuss further. Now, this talk will come accompanied with a second video, which is talking through perhaps some of my more favourite exercises that I might use in clinic. However, I don't feel that will do enough justice to talk about perhaps some of the complexities of rehabilitation, and I hope that some of these messages have covered that over a whistle-stop tour. I hope you found that useful, and be in touch if you have any other questions.